Hello and welcome everyone to my channel. I am your AI doctor. And I will be taking you through the PLAB 1 journey. We will be going to dissect questions thoroughly and get through it together. But before we can go any further, I'd appreciate it if you could like the video, subscribe to the channel and click the bell button so you can get a notification when new videos get posted. Our first series will be cardiology. We all know how tricky and exhausting it can be. But we'll make it as simple as possible. With the power of exclusion and simple thinking. Our first question is: a 65-year-old man continues to experience chest pain 2 days after an acute myocardial infarction. He has a temperature of 37.8 degrees Celsius. His ECG shows widespread ST elevation with upward concavity. What is the single most likely diagnosis? Now let's dissect the question and understand what it needs exactly. The question here states that a man aged 65 years has been having chest pain after having an MI 2 days ago, so basically post-MI chest pain. He is afebrile. But there are some ECG changes, including a widespread ST segment elevation together with an upward concavity. Now what the question is asking is as simple as the most likely diagnosis. Now let's check the options given and start discussing them. Option A: acute pericarditis. Option B: cardiac tamponade. Option C: atrial thrombus. Option D: left ventricular aneurysm. And Option E: Dressler syndrome. The answer, as you must have already guessed, is acute pericarditis. But some might ask, why is it so? The answer is acute pericarditis because, first of all, the presence of chest pain and ECG changes including widespread ST elevation with an upward concavity are diagnostic of acute pericarditis. Secondly, the history of myocardial infarction supports this. As one of the causes of acute pericarditis is a recent myocardial infarction. And finally, fever, night sweats and other constitutional symptoms may be present, depending on the underlying cause. Now let's jump to the next question and check it out. Question number 2 asks: a 55-year-old man has central chest pain that radiates to his shoulders and arm. It is relieved by sitting up and leaning forward. Pericardial friction rub is heard. A widespread saddle-shaped ST elevation is seen on an ECG. The cardiac shadow is enlarged on a chest X-ray. What is the single most likely diagnosis? Now let's dissect the question and understand what it needs exactly. The question here tells us that a man who is 55 years has central chest pain which radiates to both shoulders and arm. The pain gets better when he sits up or leans forward. On auscultation, a pericardial friction rub was heard. His ECG shows a widespread saddle-shaped ST segment elevation. And a chest X-ray was done on which the cardiac shadow is found enlarged. Once again, the question asks for the single most likely diagnosis. Now let's check the options given and start discussing them. Option A: acute pericarditis. Option B: cardiac tamponade. Option C: pericardial effusion. Option D: myocardial infarction. And Option E: pleural effusion. The answer once again is acute pericarditis. The answer is again acute pericarditis for the following reasons. First off, again, the presence of chest pain and widespread saddle-shaped ST elevation seen on the ECG are diagnostic of acute pericarditis. Reason number 2 is the cardiac shadow seen on the chest X-ray is not enlarged in dry pericarditis. Finally, a frequently heard adventitious sound on auscultation in acute pericarditis is a pericardial friction rub. What is a pericardial friction rub? Pericardial friction rub: it is a superficial, scratchy, grunting sound that is best heard in the 2nd to 4th intercostal spaces when pressure is exerted on the diaphragm by the stethoscope. Let's listen to how it actually sounds. Now let's jump to the final question and check it out. Our third and final question says a 55-year-old man had a myocardial infarction 3 days ago. He now complains of shortness of breath and a sharp chest pain. The pain increases when he breathes and is relieved when sitting forward. His respiratory rate is 22 breaths per minute and heart rate is 95 beats per minute. What is the single most likely diagnosis? Now let's dissect the question and understand what it needs exactly. In this question we have another 55-year-old man who has had an MI 3 days ago. He presents with shortness of breath and a sharp chest pain. The pain is aggravated with breathing and is relieved when leaning forward. He has a respiratory rate of 22 breaths per minute and a heart rate of 95 beats per minute. And our favorite question is once again what is the single most likely diagnosis? Now let's check the options given and start discussing them. Option A, myocardial infarction. Option B, pericarditis. Option C, aortic dissection. Option D, pulmonary embolism. And option E, cardiac tamponade. The answer is, you guessed it. It is obvious by now that this is a classic case of pericarditis. The answer is pericarditis because pericarditis is one of the differentials for any patient presenting with chest pain. Also, as seen in this question, pericarditis classically presents as sharp, pleuritic, and positional chest pain, usually 1 to 3 days post a myocardial infarction, and is relieved when sitting forward. Of course, this is just a quick review, but you can check my videos on acute pericarditis, comparing pericarditis, cardiac tamponade, and pericardial effusion, as well as acute chest pain differentials, which will help you get a deeper understanding of the subjects. At the end of this video, I want to say thank you for watching and I wish you the best. And don't forget to come back for more videos.